Thank you so much, Candace. It's my privilege now to welcome Sasha Opotowsky to the stage. Sasha is a professor in the University of Cincinnati College of Medicine, Department of Pediatrics. He directs the Adult Congenital Heart Disease program there, and he co-directs the exercise laboratory as well as the research program. On a personal note, Sasha came from Boston to Cincinnati at about the same time I left Cincinnati to come to Pittsburgh. And although we never had a chance to work together, we take care of a lot of the same patients and have interacted a lot around that space. And I'm really thrilled that he was able to make the trip over to Pittsburgh today. Thanks, Sasha.
It's a great pleasure and honor. Thank you very much for inviting me. I'm just going to pass on a message. On Thursday, a patient expressed that she was angry at you and she missed you very much. And that is something I hear quite often about Dr. Goldstein. So thank you very much for inviting me. I will say that I don't know if any of you know who this is. We're all on the same team here, but one team happened to win. This, I think, was before he won and when he was still dreaming about the trophy. So I'm very glad for the talks that came before because they really touch on a number of the topics that will come up and also some of the things that I'm not able to speak about. This quote comes from a patient who saw me. She was from down south. She was about 40, developmentally delayed, and her mother was expressing that when she was 4 years old, she asked her cardiologist, when will my daughter be able to walk? And of course, as I often do, those who know me, I jump to conclusions and assume I know what the person's going to say, but I didn't say anything, and she said, and the cardiologist said, whenever you put her down. And so it is very complicated, the interactions with exercise and activity, both physicians and parents and others, all well-meaning, often lead to patients not necessarily getting into the habit of exercise. So in a big, broad scope, I'll talk about exercise and the Fontan-Kreutzer circulation. First, pathophysiology, testing, and then treatment. And I'm going to assume some familiarity, but now I know you all are familiar after the first several talks. One caveat is that most of my information is from Tarek's Twitter account, so this better be a good talk. All right. So pathophysiology. So there are a lot of things about a Fontan-Kreutzer circulation that limit the ability of the heart and circulation to supply the muscles with oxygen. And I'll go through these relatively quickly, and then we'll ignore most of them for the talk, but it's really important to remember that there are a lot of things that contribute. There's high central venous pressure, which actually helps to augment preload. It's sort of a compensation. There's Fontan pathway obstruction or long segment narrowing, AV valve regurgitation or stenosis, less frequently, systolic or diastolic dysfunction, chronotropic insufficiency or at least low peak heart rate, abnormal pulmonary vascular findings such as abnormal pulmonary vasodilation or abnormal walls of the pulmonary artery as was shown by Dr. Kreutzer, restrictive lung physiology, myopenia, and hypoxemia all contribute to decreased exercise capacity and these abnormal exercise test findings. And there are a lot of other contributors as well, and there really are too many to get into. Things such as iron deficiency and anemia or relative anemia, arrhythmia, junctional rhythm is not that uncommon. Deconditioning, of course, musculoskeletal and coordination issues, that's something that I tend not to think as much about, but they're very frequent. Psychological factors like PTSD and anxiety, which don't necessarily manifest in the way we might expect, and pain, something we really don't think about a lot, but there has been more recently evidence showing that adults, at least, and likely children with congenital heart disease have increased chronic pain issues. The corollary is that if there are a lot of contributors, there are a lot of ways that exercise can provide a lot of different benefits in different ways. So our focus just for the next 5 or 6 minutes will be cardiac output and cardiovascular contributors to exercise limitation. So this is an equation I think many of you know, Fick equation. Oxygen uptake is a function of cardiac output and the arteriovenous oxygen difference. Cardiac output is a function for the medical students in the room. This one you'll be comfortable with, right? Soon you're going to be mad at me. But right now, heart rate and stroke volume, I could have asked that question. Excellent. For some reason, I can't seem to, do you know how oh, here we go. That's good. And together, impaired stroke volume augmentation and chronotropic impairment really conspire to decrease the peak oxygen consumption, the ability to deliver that oxygen. Now, this is an embarrassing admission. This isn't being recorded, I'm sure. When I was starting to read exercise tests back in Boston, Dr. Rhodes, you probably know, one of the nicest people that's ever walked this earth, I said to him, Jonathan, I mean, you know, this patient's peak heart rate is 80% predicted and peak, you know, O2 pulse, stroke volume is 80% predicted. Why would the peak oxygen consumption only be 64% predicted? That makes no sense. And he said, what happens if you multiply 0.8 and 0.8? And sure enough, that's what happens, 0.64. And so they really do conspire together to decrease decrease peak VO2. Some of you, a few of you who remember this paper from the PHN 2008 might remember that people really more often point to decreased stroke volume or O2 pulse, and we'll talk about this a little bit more, as the thing that's not able to be augmented in the Fontan circulation. And that is true. And if we were comparing peak O2 pulse to percent predicted peak heart rate, that might work. What we're doing is we're including chronotropic index, which is not part of the equation for percent predicted peak VO2. So really, these both contribute, and in a given patient, each can contribute importantly. So stroke volume is a function of several things, including end diastolic volume, ejection fraction, valve regurgitation. And end diastolic volume is a function of systemic venous return and pressure, pulmonary vascular resistance and the impedance of the pulmonary vascular bed, ventricular compliance and the pulmonary venous pressure, heart rate, and it goes on. Importantly, venous return is something that's not spoken about that much. And it's a really critical part of the Fontan circulation, perhaps even more ignored than lymphatics at this point. But this is a graph from a textbook on exercise physiology, which is really a wonderful book, that was looking at the blood distribution when supine and then upright. And by the way, this isn't a cool person, it's that the temperature is cool. With a hot temperature, you have skin distribution. And what you can see is that when supine, so in the cath lab, most of the time you're supine, not when you're doing the catheterization, but you can see that most blood gets redistributed to the core, and that's why people develop orthopnea and whatnot. And when you're upright, not doing much, you start to have venous pooling, and you have high venous pressures in your lower extremity veins. And then with walking, what you can see here is you redistribute blood based on the valves and deep muscles, deep veins with valves and muscle pump. And you can see here with walking right off the bat. Now that's the first thing in a normal person, a patient with Fontan, that increases cardiac output with exercise is actually that you're just pushing blood back to the heart. That's the thing that controls the cardiac output largely. And so it's important to remember that as we think about exercise physiology. And then there's this forgotten part of the equation, the AVO2 difference. We tend to ignore that. And if we get to testing, what are the things we're actually measuring when we're doing an exercise test? We're really measuring VO2, heart rate, and arterial saturation non-invasively. We don't measure these other things. One could make an argument, maybe we should measure hemoglobin, because a cardiopulmonary exercise test is a pretty annoying and expensive complete blood count. But we don't tend to do that, so we don't know what the hemoglobin is. We're not measuring venous saturation most of the time, and we're not measuring stroke volume. But we can estimate the stroke volume if we assume this is all normal or similar between people. So just ignore all that, and you have VO2 here, and you divide that by heart rate, what you're going to get is a correlate of stroke volume. Now, there are a lot of pitfalls here. So if someone has severe anemia or has severe hypoxemia, if they have issues with extracting oxygen, like a mitochondrial disease and an arteriovenous systemic AV fistula. All of those things will make that relationship faulty. But otherwise, you can do that oxygen pulse, the amount of oxygen that's being carried per beat. And what I'm showing here is two different patterns, patient 1 and patient 2. And the top patient, I'll give you a moment to think about it. Red is heart rate, and blue here is that O2 pulse, the cardiac output divided by heart rate. So a surrogate of stroke volume. And what this is pacemaker Wenckebach, and there's a sudden drop in heart rate right here. And this patient didn't notice it, probably because their O2 pulse just jumped right up. In that case, you're not going to be changing your hemoglobin or your extraction beat to beat. So this patient doesn't feel it because they're able to augment their VO2 and oxygen delivery. The second patient doesn't have anything wrong with their rhythm. You can see their heart rate goes up pretty normally, although it doesn't get up to where you expect up there. And this is a patient with a Fontan, generally doing well, but as the heart rate goes up, their O2 pulse goes down, suggesting that their stroke volume is going down. That can happen in severe aortic stenosis or a mustard procedure, but this really is a correlate of being unable to have enough venous return. And this isn't just seen in individuals. There's an average plot of stroke volume by heart rate. So the x-axis is different, but they're going to be pretty similar. And as heart rate goes up in the Fontan circulation, unlike in black here with the normal biventricular circulation, you're not able to augment your stroke volume in the same way. So what you expect with exercise in the Fontan circulation. This is a proof of principle study that was done when Gruschen-Veltman was in Cincinnati. There are 10 Fontan exercise tests and 9 control exercise tests. And what you can see here is that venous pressure goes up a lot more rapidly and severely in the Fontan circulation than in these controls. You can see at rest there is overlap, right? You couldn't 100% differentiate these two groups. With exercise, you really could, almost entirely. The same group looked at, in a larger cohort, 46 patients who had this done for clinical purposes. That venous pressure went up in almost everyone. With one patient towards peak, it went down. And they looked at outcomes and showed that that peak venous pressure is the thing that best correlates with outcomes across the board, more so than resting venous pressure. And I'm going to go through this case very quickly just to show you this hemodynamics, just to emphasize how there's a lot we don't really understand, and it's important to really think about these patients. You're lucky to have Dr. Goldstein. I feel like I might be flattering him a little bit too much, but someone who would be willing to think about this. This is a 40-year-old woman with a lateral tunnel Fontan, developed ascites, and really had a really deteriorating course over 3 years, was on very high doses of diuretics, had a very extensive workup, not much to say, had a normal catheterization with venous, with Fontan pressures and whatnot that were not normal, but they weren't very strikingly abnormal, not that unusual. Started sildenafil, which we are wont to do when we're not sure how to help somebody. Not only did this patient not improve, but she developed a headache and almost passed out a couple times. So we stopped that and we did an invasive exercise test where we put it in a venous line and had her get up on a bike and do true fit cardiac outputs from a radial line and a Swan-Ganz catheter. This is a patient who had severe PTSD. Lovely person, seemed like she wasn't overly anxious about most things, but the moment that a needle came close to her, it's very stressful when someone has no sedation, since they're gonna have to exercise right after. And despite numbing, it was really very difficult for her. But what you can see here on the left is the Fontan pressure doesn't go up. In fact, when she goes from supine to upright, the venous pressure drops precipitously. The wedge pressure drops quite severely, and it just doesn't augment at all with exercise. Cardiac output doesn't really augment much, and PVR, probably because of decreased flow, goes up when she gets upright and just doesn't go down with exercise, okay? In any normal individual, PVR should go down with exercise, cardiac output should go up a lot more. So what you see here is the limitation isn't, the wedge being high, so it's not systolic or diastolic dysfunction, it's not necessarily PVR, because if it was PVR, the venous pressure would go up. The issue here is that she has very high venous compliance. So, if I can figure out how to change this. Oh, do you guys know how I do this? Oh, thank you. Venous capacitance going up is a major issue. So we don't see this too often, but it does happen, and it's something to keep an eye out for in terms of exercise physiology. I'm going to skip over this. And we sort of see hints of that, right? You have these patients with very severe varicose veins. That's not just happening in the legs. And it turns out that phosphodiesterase inhibitors like sildenafil and sildenafil are also venodilators. Finally, treatment. So here's some Argentine exercise training. It's amazing. For Lionel Messi, there are a lot of pictures of him exercising. For Maradona, there are almost none. I wonder why. There are a lot of types of exercise. And one thing to highlight is that when this patient asks you, well, exercise can be harmful, okay? And for many decades, that was the standard. We really don't know what types would be most harmful. And I just wanted to highlight, this is last night when I was going over these slides and looked, my Google Scholar gave me a hint about this paper, which looks so incredibly cool, that they basically looked at a lot of different markers of possible liver injury in terms of ultrasound and circulating biomarkers after exercise to look for liver damage. I haven't read it in detail, but right after this I'm going to. But this is the sort of thing we have to do to try to identify what sort of injury we could be doing with certain sorts of exercise. But there is clear consensus, and I agree that we should strongly encourage exercise. So what data support that shift? And I'm going to skip through this pretty quickly. Reasoned arguments and randomized controlled trials. There's other evidence, but we're just going to focus on these. Reasoned arguments are great. So in populations where it's been studied, exercise is good for you. And it also increases muscle mass, improves endothelial function, and improves ventricular compliance. And all of those things are fundamentally important. And here's a paper showing the increased adiposity and decreased muscle mass in a Fontan. You might say, we know that a decline in VO2 in this population is associated with worse outcomes. So if exercise and training improves peak VO2, maybe it'll be associated with improved outcomes. Fair. But I love this exercise, but I've heard you say that love's reason without reason. Well, that's okay, right? We don't necessarily have to have a reason. I think we all agree, and it's probably good. We should try to figure out why, and it probably doesn't do major damage. And so we have to go ahead and start to think about exactly how we counsel patients. I'm going to skip ahead here, just highlighting here how little data there are on that this is actually beneficial. Given how strongly we recommend it, it's quite surprising how little we know. But it's important to remember why a patient is interested in exercising, right? There are a lot of reasons, but peak VO2, having better vascular function, better cardiac function, none of those are reasons unless they have correlations with something else, right? And so you can actually, we've all seen a good number of patients who feel a lot better and are doing a lot better when they exercise. And it's important to remember that that is an end in and of itself, even if on average it may not have a huge benefit. So what we know is being sedentary is bad and exercise is beneficial in most contexts. The benefit is not limited to peak VO2. Exercise training does improve exercise capacity, and it's usually safe. We do know that cardiac rehab is effective in certain situations. Few people, though, sustain regular activity, and there are obstacles to these patients, especially feeling comfortable exercising. There are a lot of open questions about how we're going to do this the best possible way. And the good news is that on the horizon, there are a good number of more rigorous, robust studies that are being done in Australia. These are Australia, Stanford, and Michigan. And I just wanted to highlight, there are also things that are not clinical trials that are ongoing. This is for the Fontan Outcomes Network. Our first clinical care practice project is really getting patients, parents, providers, and others together to understand better what's limiting us and understand the importance and how best to support patients and providers in how we counsel patients to improve physical activity. And this is from a learning session where we all started squatting. You see this really impressive guy back there? I think that's me. And with that, I say thank you. We are all on the same team if Pete Rose and whoever this other guy is could get along.